Hi everyone, welcome back to our channel. Today we are joined by Professor Peter Brennan. He is a Professor of Oral and Maxillofacial Surgery and also works as a researcher.
Thank you very much for joining us. So could you please tell us a bit about your background and sort of how you got into research after your medical degree?
Yeah, thank you very much, and thanks very much for the invitation, and pleasure to speak with you, of course. So I qualified from King's in 1994. Seems like a long time ago now, and I did my surgical rotation in Addenbrooke's in Cambridge, and I had the good fortune to work with a world leader, actually based in surgery, a chap called Professor Roy Khan, who you may have heard of, who did the country's first liver transplant and kidney transplant. But he discovered cyclosporin and 6-mercaptopurine, which was an immunosuppressant that was used before cyclosporin, and basically kind of opened my eyes to research and how you can do research alongside a busy job as a surgeon, and basically got the bug from him, I guess, and I looked at him with some awe. He's one of the few surgeons who has a FRS, Fellow of the Royal Society, so and a Knight as well. He's a Sir, so he was one of those early inspirational figures, really. And then as I started my training pathway in oral and maxillofacial surgery, I became interested in head and neck cancer, some of the basic science, but never really kind of lost track, if you like, with clinical, and so saw myself at a very early stage as never being a true academic in the sense of the word, and not I didn't see myself as an academic, a university academic, but very much a surgeon with an academic interest. So then, of course, the next thing is do you decide to pin your colours to the mask and do a higher degree? And in Max Facken, at that time in the late 90s, 2000, I think it was, there were very few people, because of course, doubly qualified, you've already done a dental degree, so I was 5 years older than everyone else. So decided to do an MD, which I did in cancer angiogenesis, so how cancers get a blood supply. And again, the second good fortune, I was lucky to work with Salvador Moncada, who again is FRS, Fellow of the Royal Society. He discovered how nitric oxide works. He also discovered the mechanism of action of aspirin back in the late 70s. So he had 3 papers in Nature for those, and the NO work, and should have really got the Nobel Prize, because he published in Nature ahead of the American group, but because of politics and things, the Nobel Prize for NO went to a chap called Ignaro. But nonetheless, I wrote to Salvador and said, is there any chance I could get involved and things? And so I spent some time in his lab at the Wharton Institute in London, got some funding for the Royal College of Surgeons. I took a year out of my surgical training, and I did my MD. I completed it in about 9 months, which I think is probably quite a record. I don't know. So then I did. yeah. Like all these things, it went really well. And then I did 3 months at the end, basically as locums, paying my way and some on call, and trying to get back into the clinical work. And then recommenced the rotation in 2001. Yeah. So took a year out effectively.
Yeah.
I don't think it makes you a better surgeon or a better clinician necessarily. I think I'd really stress that if you're going to do research, yes, it gives you perhaps a better understanding of research methodology and understanding publications and writing, of course, and contributing to medical literature. But I don't think it necessarily makes you a better surgeon or clinician or endocrinologist or whatever you want to do. That's really important. So you still have to do the clinical time in your training. And I guess for me, in surgical specialty, if you're going to take a year out, you almost start to de-skill. So it took me a few months then to catch up any skills that I had and to regain those. Yeah.
Did you ever consider a different career path at all?
Yes, I always wanted to be an airline pilot, if I'm honest with you, and so that's probably not what you want to hear. But my parents, or my father particularly, sort of said it was a volatile market, and of course it's dependent on your health and regular medical checks and what have you. And of course, if anything goes wrong, then you're in trouble. So I guess that in a sense has brought me round to my latest research on human factors and actually working with the airline and the various BA captains and things. So it's amazing how fate has a twist in all of this, isn't it, really?
Yeah.
But I guess if I had my time again, probably I suppose it's a dream, really, and you speak to the BA guys and they look at us as medics with some awe, and many of them have been into theatre and see me operate and things, and they're they look in awe, and they said, you're making a difference to patients' lives, whereas we take people from A to B. So I guess the career change, it is a dream, but I'm glad I made the choices, and I'm very happy doing what I do and helping others, making a difference, looking after patients.
Made the right choice anyway.
Well, I hope so. Yeah, it's too late now, isn't it?
It's never too late.
Yeah, it's probably too late now, I guess. Yeah.
Has that inspired a lot of your research? Because I know you do a lot of your research into patient factors, and you do compare surgery to airline pilot.
I would say people look at me and think, I've got 600 odd papers now, and I've got I think my H index, which is the number of times your papers are cited over the thing. So mine is about 45, which is the same as a Harvard professor, basically. And but I'm very much a jobbing NHS surgeon, so I'm not funded by the university. All the research I do is in my spare time, basically. And I bring people together. That's how I guess I've been successful. So I would say I'm very much an opportunist. So I'm a bit like Candida, Candida albicans. It's an opportunist. It comes along when you're diabetic, when you're run down, when you've on steroids, what have you. And I'm opportunistic in looking for research projects, looking for things that will make a difference. So if you look at my research overall, I've got two main themes. One is on cancer biology, which is now dying out, if you like, because I haven't got time to work in the labs, and I haven't got time to lead a basic science research group. So the human factors, I stumbled on that probably about 10 years ago with a retired airline pilot that had a nasty jaw cancer, and we ended up doing major surgery on him. He then developed every complication under the sun, not related to the surgery, I have to tell you as well, but he developed a vasculitis, probably an antibiotic-related vasculitis, and he ended up in ITU and whatever. And one of his friends, who's a British Airways jumbo jet captain, used to visit this guy every day, and we ended up striking up a bond when I used to go and visit him. And he said he always wanted to be a surgeon, and I wanted to be an airline pilot. So I got him into theatre, which was amazing. He got me on the simulators at Heathrow, and I managed to land these jumbo jets and Airbuses and things, and amazing. But he opened my eyes really to human factors. So team working, effective communication, looking after yourself, taking the regular breaks, all the things perhaps that we don't really look at, or we didn't, and that really started my research into human factors, and started looking at what the perception was amongst healthcare, and published a bit on that, and then built it from there, really. And then I guess became so interested that decided that I wanted to do a PhD on it, which was probably crazy, because I already have an MD and I have my honorary chair, and as I said to you, I'm not accountable to the university having a personal chair, but really, really glad I've done it. And it's I guess you've got to enjoy doing what you're doing. I mean, you two are doing PhDs. You're doing it hopefully because you enjoy research. You want to do it. You want to get a lot out of it. You want to help others. Those are the reasons for me for doing it, and that's certainly why I did the PhD recently. I actually enjoy doing it, not because there's an obligation to do it, and that's really important.
Yeah, I think definitely one of the things that we would say to people about doing a PhD is that you definitely need to enjoy your subject area. It's a very intense workload for a short space of time that you really need to have the enjoyment. There's a lot of self-motivation that you need to put in. One of the things, you've kind of answered it already, but you mentioned about an MD and a PhD. We actually had one of our viewers commented who we presume is a medical student at the moment. They're quite confused between an MD and a PhD in terms of deciding between the two. Would you be able to just talk a little bit about your initial decisions to do an MD? And then
well, I'm still confused by it. So okay. So my understanding is that an MD is probably 2 years. I mean, if you're crazy like me, you could. And I was working in the lab till 11 o'clock a lot of nights, but I wanted to do it in a year, basically. So an MD is a unsupervised, in inverted commas. So yes, you do have a supervisor, but it's not supervised in the same way as a PhD.
Mm-hmm.
A PhD is 3 years full-time, and we're talking about full-time here. So an MD is a 2-year full-time, a PhD is 3 years, and that's a supervised degree, and that really, I guess, goes into things in a lot more detail. Perhaps it's a bit more scientific. An MD may be a bit more clinical, although of course you can do lab-based MD research, as I did. I guess the crux of it is what do you want to do long term? Do you want an academic job and you want to be a university lecturer, senior lecturer, university professor with some clinical input, or do you want to do like what I've done, be very much a surgeon, a clinician, a neurologist, whatever you want to do, and have some academic? And so if you want to you want to be an academic professor in a university, then maybe a PhD. But actually, when you look at it, if you're going for an academic post, the criteria are you have to have a higher degree. So that could be an MD, an MS, a Master of Surgery, or a PhD, or a DPhil from Oxford, or what have you. You don't have to have the PhD or the MD. And I think also it's important to stress that once you have the degree, what are you actually going to do with it? So if you have a PhD and you don't publish, or you don't help others, then it's almost dead in the water, So carrying on the work, furthering, publishing, that for me would be the key. But I'm an amateur, if you like, because I'm an NHS consultant with an academic interest. I just happen to have been really successful with academic, I suppose. But first and foremost, I am very much a surgeon.
You kind of touched on it anyway, but do you sort of go into a bit more about what would a medical career look like? So if they went into research, say after medical school. So I know there's I'm sure a few different paths and everything, but what would you think that career would look like?
So there are academic foundation jobs now coming out, and then there's academic clinical fellows and things. So I think you have to get registered with the GMC. So you have to do your two years of foundation, of which part of that could be an academic job, and you then have to get a CCT, a certificate of completion of training in your specialty, in order to practice as a consultant, or as an honorary consultant if you're university. So I guess it's going to vary between specialties, between what you want to do, but you're also going to have to, if you want, and I'm not saying that everyone does have to do a higher degree either. You could, if you want, if you want to be an NHS consultant and you want an academic interest, you could get involved in some research, a research group, Most universities have those. So I work in Portsmouth. It's a big district general hospital. Yes, we are now a university hospital, but there is a lot of research that goes on within hospitals that are not university hospitals. So you can get involved in that at an early stage. Test your toe in the water. See if you like doing that. Most colleagues will help you and will support you and will give you projects to do or to get involved in, and then it's up to you to deliver on those. So I think, if you're starting out and I'm going to be an academic, I'll get involved in that project, and then you do nothing, people are then going to shut the door on you. That happens. You have to almost prove your interest. And I think it's not easy, actually, because, as I've mentioned, not only do you have to get your completion of training certificate to enable you to practice as a consultant, but also you're developing your research interest as well. So it's almost doubly as difficult.
You mentioned a little bit about having a split role, and you mentioned that you work in research in your spare time. Would you advise that? And it links probably into one of the questions that we wanted to ask you a little bit later, but in terms of how busy it's been with your clinical commitments, how would you say that having a split role that's not defined by a university institution works?
Yeah. So I've actually been really lucky in that my trust has been very supportive, and they've now given me, or in fact, very, very shortly after being a consultant, I was given time to actually do research. So it was paid by the hospital rather than university. So I get basically half a day a week. Until a few years ago, I had a day a week, but because of head and neck cancer rates going up and things, I'm now doing half a day a week. But as a consultant, you also get some time called supporting professional activities, or SPA, and I get 10 hours a week of SPA as well. So I use a lot of that for my other commitments. I have a big role for the College of Surgeons, for the MRCS exam, all sorts of other things. But I do use some time for that as well. So you could say that I have almost a day a week, perhaps, paid by the trust to do research, and I think that is easy then if you're not accountable to the university. So as a university lecturer, senior lecturer, you're going to have to demonstrate you're bringing in grant money, you're publishing papers and things. I don't have to do that, actually, and I think the university have said, yes, here's your personal chair, and we'd like to see one publication from you a year. Well, that's very, very easy to demonstrate, of course.
Was that one of your reasons for, I guess, deciding on that pathway rather than wanting to be affiliated with a university and have a senior lecturing?
Yeah, I think having spent all these years training and spending 5 years after the surgery exam, it was the FRCS in those days. It's now MRCS. So spending 5 years of specialty training, I wanted to be a surgeon, and right at the centre of what I do is patient care, trying to save people's lives. The highest standard of surgery that I can provide, training the next generation. I love doing that as well, and training junior doctors and registrars. So it was always, for me, the research was, I think we said at the start, was a kind of an extra, if you like, as opposed to Professor Khan, that was very much a university professor, and I think he was on 8 or 9 sessions from the university, and he would operate half a day, 1 day a week, and that was it. Very, very rarely see patients.
Yeah.
And that worked for him. So it's very much what you want, and I would say to you that a lot of people perhaps won't know at this early stage what you want, and so don't commit at an early stage and say, yes, I definitely want to do a PhD, unless you're absolutely sure you want to do. Test your toes in the water just to get a feel for it, because you might do some research and actually decide that you don't like it.
So for you, what do you feel are the benefits that you get from doing research as well as your clinical role?
So I get a lot of personal satisfaction. Um, it's great to know you're making a difference for others. So not just on an individual patient basis, but for many patients. I mean, the human factor stuff. Just to give you an example, I think this year 3 of our HF papers are the most downloaded papers in the journals, and so and last year we had an article in the BMJ, and you're looking at tens, 20s, 30,000 downloads plus for those, and so you know that people are reading them, and it's actually making a difference to them. So a lot of personal satisfaction. Every single time I see a paper with my name on it, it still gives me a buzz, despite the numbers. And as I said, I really enjoy helping others. So getting their first publication, getting them onto the ladder, helping them along, and that can start at any stage. So as a registrar, I was helping the same as foundation doctors, basically house officers, pre-registration house officers, get their first publication. And so you could be helping medical students get their first publication. And we do have medical students coming to us as well. I'd like to be involved. And so I give them something to do, and then they get a publication, and it's a great feeling for them. Fantastic. And what a great feeling for us, getting them on the journey. Yeah. So a lot of satisfaction.
You've mentioned this a little bit about your negotiation, and that you were saying that in some cases, especially clinical academics, they have limited clinical time if they want to go down the academic route. One of our viewers was wondering whether they would have less patient-facing time if they were to do research. So I was wondering whether you can just talk a little bit about how that negotiation with the trust goes if you're not going to consider the PhD route and then splitting your role with an academic institution. How does it work to make sure that if you are really interested in having more clinical commitments, how that actually works out in practice?
So most jobs, I mean, obviously when a job is advertised, it will be prescriptive, and it will say this is a 10-session job with eight patient contact things and two SPAs or supporting activities. And if you're interested in research, then it might be, even before you go for an interview, it would be worthwhile saying, look, I'm interested in this. Would there be scope for having this, that, no? And that's what I did actually. I went and said, look, yes, I want to come as a that's what I want to do. But is there any scope for doing research? The other way around, of course, is if it's an academic job and there's limited clinical, then again there's always scope for discussion and negotiation. And I've only got three sessions, for example. Would there be scope to giving me 4 sessions or 5 sessions of patient contact, and actually maybe having slightly less research? So I think nothing is usually cast in stone. There is scope for negotiation. The way you go about negotiation is absolutely critical. Don't go in there with a bull in a china shop, and I need this or I want this. That's gonna put up antibodies straight away. Yeah. You have to try and sell yourself as what you're coming to do is going to be of benefit to the department, your colleagues, and the trust or the university. And once you sell it like that, people tend to open doors. I'm not saying they do all the time, but and I've had more or less on a yearly basis at the job planning sessions. They say, oh, actually, I'm going to take your research session away, and it's like, well, actually, no, that brings quality, it brings development, quality improvement, it brings all of the things, and then of course, oh yeah, that's fine then, and then it goes away again.
I know you said before that for your specific role, you don't have to publish, say, to bring it, or you don't have to prove that you can bring in grants or anything like that. But do you yourself have sort of a aim, say, per year to keep publishing a certain amount, or it's not governed by your job, but do you personally have sort of an aim?
So rather embarrassingly, so the year to date, we've published about 20 papers. About 14 on COVID, so human factors and things, mainly around COVID. And so I don't set myself, this year I'm going to write 3 or I'm going to do 5. It's as I mentioned at the start, I'm an opportunist, and people come to me, trainees, others come to me. Oh, I've got this idea about this. What do you think? It's like, wow, that is fantastic. Right, okay, we'll run with that. So I've just come off a teleconference earlier this morning with my intercollegiate research fellow who's doing a PhD around surgical predictive validity, so around whether the MRCS predicts success in the future. So we have all the GMC data around fitness to practice. We've got medical school data. We've got even high school data about whether you're state or privately educated, and we're doing lots of work around that. So he's actually running with a lot of that work and doing a lot of the work. And I'm supporting him, of course, and supervising. But we're already talking perhaps about another 2 or 3 papers that we didn't really think of that are suddenly going to happen. So there's going to be another 3 or 4 there, you see. So it's I think if you have to, if you're tired and the university says you have to do this, that I find that difficult. I prefer to do it at my own pace, and as I say, just enjoy doing it. That's the most important thing. We're a long time dead, and so you've got to enjoy your time. And if you're doing it because you have to do it, or actually you don't want to do it but you have to, there's resentment. Your research quality is not as good, and things. You have to do it because you want to do it.
You mentioned a little bit that you enjoy teaching the medical students and the registrars. Do you do teaching within NHS setting, or do you do teaching within the university?
We have medical students that come to us. So we also have dental students that come to us from Cardiff. And again, some are more interested than others. And so I think, if you're interested and you're showing your trainers, your consultants that you're interested, you're going to get a much better experience. If you come along and you're sitting there on your phone like this and you're disinterested, then you're probably not going to get such a good experience. But yeah, I get invited to lecture. I lecture in the medical school. I get invited all over the UK and beyond, really, to talk both about research and all the research that I'm personally doing. So I give lectures about how to get yourself published, how to go about research, success in research, which is quite how you define that, I don't know. So amount of grant, number of publications, the impact that it has. So I could have all of these publications and no one reads them, but so then it's of no impact. But for me, it's all about, is that paper going to have impact? Is someone going to read that and think, you know what, that makes a difference? That's what's really important. So, and I try and teach that to the medical students, to foundation, to whoever's interested at that early stage. Do it because you want to make a difference. You want to have impact. You want to leave better than when you arrived.
I presume that you're the same way that you're invited to do lecturing. I presume that you're invited to conferences and things like that as well.
Yeah.
When you do the conferences, is that, I know you mentioned that, say you get 10 hours or something of academic work.
Yeah.
Do you take that out of that time, or is that something that you have to take leave for?
Yeah. So we get so make the most of your study leave, okay? Because junior doctors get up to 30 days a year of study leave. Consultants will have 10 days a year maximum. There's then something called external duty. So again, it's actually discretion about how much time the trust will give you. And if the trust feels that the work is of importance and it raises their profile as well, they will give you time. So again, I've been really lucky that my trust is very supportive, and particularly with my roles for the Royal College of Surgeons, of being elected onto the council of the RCS is of benefit to them because you're helping to direct strategy and the future of UK surgery. So, you know, it's a game, if you like. It's a two-way thing. You know, if you're hard-nosed about things, the trust's going to be hard-nosed with you. If you're prepared to see extra patients, do the occasional extra clinic, work a bit extra overtime, you know, come in early to sort things, then the trust's going to support you. It's a two-way process. Really important. Don't be hard-nosed.
Do you think that with your trust now being a university hospital, that might make those, I guess, decisions around research activity a little bit easier than, say, a trust that's not a university hospital?
Yeah, I guess so. But, you know, again, I mean, our trust wasn't a university hospital until 3 or 4 months ago. And, but, you know, across the hospital, we're one of the biggest recruiters, international trials of any hospital in the UK, across all the specialties. You know, most doctors there are committed to trials, to research and things. And whilst there might not be a chief investigator or a lead investigator or what have you, you know, they want to contribute. So it's a kind of ethos thing, really. Yeah. And I think it's a top down as well as a bottom up. So if you've got the executive team really keen on research and supportive, that's the top down filtering. And then you've got people at the bottom, you know, the foundation doctors and things wanting to do that, and you kind of meet somewhere in the middle. But I think if you have a research interest and you're not working in a university hospital, you can still do some really, really good research. Yeah. Don't ever forget that. You can, you know, because if you think I did that for 10 or 12 years, you know, you can do that. Yeah, definitely.
I had a couple of questions from, again, we presume medical students who are potentially not so keen on doing teaching or anything like that after the degree and just sort of want to do the clinical role as well as a bit of research. Would you say that's fair, like possible, and what would you advise for them?
So I think medicine is all about, it's almost an apprenticeship, and I think if you look at the GMC as well, there's almost an obligation to provide some sort of teaching and support for you know, doctors and medical students who are coming up behind you. So I think someone that says I'm not going to do any teaching, then I find that quite hard to swallow. And you know, if that is their attitude, then they might find that trainees don't want to work with them. You know, that, you know, trainee doesn't want to be in theatre if they're not going to be taught, or a ward round on diabetes or whatever if they're not going to be taught. Well, why would I go and work with Dr. So-and-so? And that actually happens. You know, people lose their trainees because they see it as not a thing. So I think you need to be very careful. So I think there is certainly a teaching element, no matter what you end up doing, unless you're just working in the lab. And even then, of course, you know, you're then going to have research students and things, and there's an obligation then to supervise and train and teach them. And the same for research, I guess. You know, if you just want to do a bit of research as well, then how are you going to do that? You're going to want people to help you, and then when you then get to the stage when you're doing it, then surely then if people have helped you, there's an obligation to help others. Does that sort of answer what you think? But certainly read the GMC documentation around training and things, because the GMC feels very strongly that we have an obligation as doctors to train.
One of our questions, I think, might come from a panicked 4th or final year medical student. They've asked whether you have to score the highest in your year in order to be competitive enough to be able to get onto the academic foundation programme. Right.
Okay. So personally, if you want my honest answer to that, I think there is competition and there is competitiveness. Yes, there is. But my A levels were really mediocre. You know, I failed numerous exams along the journey. I failed the FRCS as it was in the late 90s twice, and thought actually I was going to leave and maybe do aviation after all. I think if you're going for a competitive post and you haven't done quite as well, then, and you don't get that post, then fate has taken a hand. You know, we mentioned that. And so get into your job, start enjoying your job, and actually work out if that's still what you want to do. How can I start putting things? So, you know, can I attach myself to someone and get involved and write a paper, or could I do this? And just start building your CV that way. When it comes to consultant appointment, the most important thing is, you know, if you've got six people come in for a consultant interview, which one are you going to appoint? You're actually going to appoint the one you assume. Obviously, all of them are technically competent and they've got good skills, etc. But you're probably going to appoint the one who's going to fit in well, who's nice to work with, who's going to be able to swap the on-call at short notice, who's not going to be belligerent, who's, you know, and that might not necessarily be the one with the most publications. So yes, medicine is competitive, but there's actually so much more to it than that.
There's another question from one of our viewers. They're on specialty training at the minute, but would eventually like to have sort of a split role into research. And I think they just wondered, can they go into research, say, later in their career?
So there is, as part of specialty training, there's OOP-R, which is out of program for research. So it is possible to take time out, and that can be discussed with educational supervisor, training director, and then that post is usually backfilled. So that's a kind of almost like a standalone post, and then you have to seek funding from either the college or an institution to actually fund you to do that. And a lot of people do that actually, and so they get halfway through, say, their surgical training, and then they decide, actually I want an MD, and so they drop out. And in fact, this is what my intercollegiate fellow's actually done. So he's halfway through his surgical training. He's decided he wants to do this because he wants to have a PhD, and he sees a future in academic surgery. And whether that's as an NHS consultant doing a bit or the other way around, we don't know. So he's taken 1 year out in the first instance, and then may extend. So anything's possible. Yeah, I think, you know, if you hear someone say it's not possible, then you need to go and speak to someone else. That would be my advice. Anything's possible, always.
I'm sure that's really helpful to whoever's been asking the questions. I presume that they are quite nervous about their career path, so I'm sure that's
yeah. You know, just if you find that and someone says no, you can't, then just go and speak to someone else. And you know, like in medicine, just doors. People go around, me included, even at this stage. You know, I go around knocking on doors, and some doors open and they pull you through. Some doors open and shut again. Some doors open and you get halfway, and then you get stuck in the door. You know, so if you knock on a door and it doesn't open, move along to the next one.
Yeah.
You know, and even if that means going to speak to another specialty, or a related specialty, or another consultant or something, there are always ways to get around and to achieve what you want to achieve. Always.
Just keep persevering.
Always. Yeah, absolutely.
One of our questions was about, I think probably one of the most difficult questions maybe to answer, is just how do you balance both your professional commitments and also a personal life as well?
so yeah, that's a really, really good question. And you may have seen on Twitter that I have clones. So I managed to clone myself. That's a really good question, and the answer is that it's all about time management. Yes, I do walk away from work. So most weekends I don't do work. I don't bring work home at weekends. It's really important to have that work-life balance, involving others, I think. So you know, make sure you take the holiday. Let's get these out of the way. Make sure you take the holiday. Make sure you plan things. Make sure you have good quality time. You know, whatever. So that's the hobbies and things. You know, all those things. In terms of the work, my clones is basically collaboration with others. That's what it really means. So so we might have 4 or 5 different papers that we're writing at any one stage. And so, you might be taking a lead on that one, someone else is taking a lead on the next one, someone else on the next one, someone else. And then suddenly, if you've got a group of trainees together that have an interest, you might be doing the work on one of them mainly, but then suddenly you find your names on 5 papers because you're doing a little bit of work for others. But don't whatever you do, get into a situation where you just work because you'll burn out, and then perversely, then your performance will suffer. You won't achieve. You'll get frustrated. You get onto this slippery slope. People get depressed. People disillusioned. I've had a paper rejected, so and it might be because it wasn't written well, because you're trying too hard or what have you. So work-life balance, absolutely critical, really is. Yeah, most definitely.
As we all know, this year's been a bit upside down, really, with COVID and everything.
Still is.
How has this specifically impacted both your surgical role and your research?
So surgically, it hasn't really impacted it at all. So many of my practices had neck cancer. So initially we had probably about 2 or 3 weeks of relatively few cancer waiting patients, fast track patients coming in because the GPs had shut up and things, shut up shop. But that very quickly resolved itself, and I think I've only had about 3 or 4 lists in the last 6 months been reduced or suspended. So my clinical work hasn't suffered at all. If anything, I think I'm probably busier than ever, to be honest. In terms of research, we saw COVID as a great opportunity. I mentioned that I'm an opportunist. I'm a bit like Candida, so I saw that as an opportunity to look at some of the human factors around COVID. So wearing the PPE stuff, for example, how do you communicate effectively? So we've written 2 or 3 papers on that. A core trainee from Cambridge got in touch and has done a systematic review of training at medical student level for pandemics and disasters. And so he'd looked at all of the publications related to that. It's like, wow, and so some work on that. We now have a publication on a systematic review, which is a really powerful research methodology, as you know. So that's published. So I've kind of used the opportunity to change slightly, I guess, and looking around COVID. And as I mentioned, some of those papers are the most downloaded papers. So I think I've got 3 of the top 5 most downloaded papers in the British Journal of Maxillofacial Surgery at the moment. 10,000 downloads each, sort of thing, and they're all COVID-related papers. Getting the most out of a virtual meeting is another one that we've just written. So taking the break, making sure you get a coffee, respecting that there won't be non-verbal clues there. Enabling, if you're on a committee, enabling someone who might not speak up, giving them a chance. Have you got a comment? So you maximise the opportunity, and actually written more papers in the last 6 months as a result than I would have done usually, to be honest. So I need to take a break now. Yeah, definitely.
Take your annual leave.
Yeah.
So when thinking about how COVID is impacting cancer referrals and things like that, for patients that might have symptoms at the moment, what would you advise those patients?
Don't hesitate if you have a problem. So in our specialty, it would be neck lumps, non-healing ulcers, whatever. But it doesn't matter what the specialty is. A breast lump, bleeding from the back patch, whatever it is. Don't hesitate. Go to your doctor and get referred, because most cases, and the good thing is 97%, I think it is, of fast track referrals turn out not to be cancer. So that's reassuring. It's unlikely that it will be, and there's a lot of other things it could be. But if it is, you need to diagnose early, and that's to stand the best chance of cure. So so that would be my advice. Don't put it off. Go and seek professional advice, and exclude. That's the thing. And people think, and they come to me, I've looked you up on the internet. I've got cancer. It's like, no. Let's just have a look. And then they go away reassured that they haven't.
So we know that you've written a few books. I think you mentioned it earlier. Could you talk about how you got into writing books, and maybe whether you have any plans to write any more, or the difference between writing a book and, say, a journal article?
Yeah. Okay. So again, that was luck. I was contacted in 2010, I think it was, by a consultant that was editor of an operative surgery book, and he said, "Oh, would you like to be involved in that?" It's like, wow, and so as one of the editors, I had to find authors, and I had to, I wrote a couple of chapters myself, and that was a steep learning curve, to be perfectly honest with you. And yes, it's not necessarily the same as writing a journal article, because it's, depending upon what the book is, it's sort of dissemination of knowledge, and how I disseminate that in the nicest and easiest way, with diagrams or what have you. That led on to the Oxford Handbook of our specialty, which I'm an editor of, another lovely book, and then I started getting my own ideas. So I edited a book called Clinical Head and Neck Anatomy for Surgeons. So there isn't a book out there of head and neck anatomy for surgeons with surgical pictures, and this is what you can do, and beware of this structure, and if you go off this path, you're going to get bitten by a tiger, that sort of thing. And so on the back of that one, I then got invited to be the lead editor of our 2-volume 1800 page textbook of our specialty, because the chap was retiring, and he said, always ask a busy man. So that's why they came to me, and that was an honor. And I guess on the back of all of those, the Gray's Surgical Anatomy, which is the latest one, is what a enormous honor to be approached for that, really. And so I think Gray's is an amazing textbook, but you can't really learn anatomy from it to do an operation or to go onto the wards and do neurology. And this book really brings Henry Gray's concept from 1858. So it's called Descriptive and Surgical Anatomy. And his original book was very much a book for surgeons. Right, this is how you do this. This is the structures. And so we've brought the book back into the 21st century, and included a chapter on human factors right at the start, to minimise error in theatre. So yeah, I think being in the right place at the right time, enthusiasm, enjoying what you do, having a vision, and seeing what you think the final product's going to look like. The Grays is I still can't get my head around the Grays. It's sold out within 2 months of going to press. So Elsevier, the publishers, had to reprint it within 2 months, which is apparently unprecedented. We've kind of reduced the royalty, so we get a very small amount. So don't think, if you're going to write a medical textbook, don't think you're going to get rich, because you ain't. It doesn't work that way. You get a very small amount because of all the production costs and things involved. It's not a money spinning exercise at all. And I've made out of all of my books probably just a few £1,000s, which if you put it into context with private work, you could do a few hip replacements if you're an orthopedic surgeon, or a facelift or whatever it was, and that would probably earn you as much money as what I've earned over many years as a book editor. So you're doing it because you want to make a difference, you want to help the next generation. All of those reasons we discussed earlier. And the answer is yes. We've got two more books coming up. I said I wasn't going to write anymore, but of course, I've been asked to edit a new Bailey and Love book on oral and maxillofacial surgery, and then of course all the books that we're editing as well. So the Grays will come round in 2 or 3 years' time, and we'll have to update that as well. So I'd be delighted to get trainees and things involved, and we have got many trainees involved in the Grays, and their input is invaluable because they see things slightly differently, and they see it as a trainee would see it, rather than me seeing it as how I think a trainee might see it. And I might be right, I might not. So inclusivity, I keep on saying that word, but it's so important. So yeah, I'm blown away by the books, and I've got them on my bookshelf, and I still can't quite believe I've edited 6 or 7 textbooks, to be honest. It's surreal. Yeah.
And do you find that process a little bit more challenging than, say, writing a manuscript, or would you say that they're quite a similar process?
It's yeah, it is really. I guess if you're writing a chapter, so if you're an author of a chapter, that is like writing a manuscript in the same kind of way. You know, you'll have set instructions of the length of it, what they want, what needs to be included, what not. In terms of editing, you're kind of, you know, you're going to go through all those chapters. You're trying to balance, oh, this chapter's far too long, or this chapter there's not enough, or maybe we should have done this. And for me, the key is none of those books is just me on it, you see. So I've actually got others involved, as I said. So the Greys, we've got Susan Standring, who's the editor of Grey's Anatomy itself, and another surgeon from the States. The Max Fact books, I've got 3 or 4 co-editors with me, and that's inclusivity. It reduces the workload. It means you can bounce ideas off of each other and things. So I guess in some respects, very much like a manuscript. Actually, you'll see very few papers of mine that are just me. You know, there's always multiple authors for that very reason, really. It's a different, yes, it is different editing. It's I mean, the Greys in the final 6 months, we had something like 4,000 emails bouncing around between us. So trying to find the time to do those was a challenge. And you know, if I was going up to London on the train for a Royal College of Surgeons meeting, then I might use that time while I'm sitting on the train. You know, that's why I talk about time management. But yeah, so different challenges, but nonetheless so rewarding, and I still can't believe I'm the editor of the Greys. You know, in 100 years time it might be worth something. You know? And you know, I did a video for King's College, actually. So they asked me to do a friend of mine's a senior lecturer in anatomy there, and we were medical students together. And so now he's a senior lecturer, and he said, you know, he's actually they bought 7 or 8 copies for the library at King's. And he said, could you just record just a kind of 2-minute video about anatomy? And so I did. And in that video, I said that I found anatomy really, really hard. And please don't tell anyone, but you know, I really struggled. I failed a couple of vivas. I found it really difficult because it's like a foreign language. And when you're learning it, you know, particularly if you did it like we did on the preclinical side, and you wonder what the relevance is to any of this. And then coming round 360 and being the editor of the Greys, it's, you know, and what I wanted was to have a book that people could read and enjoy reading, with some nice pictures and things, and trying to make it easier to understand.
I was just wondering, what one piece of advice would you perhaps give to medical or PhD students?
Number one is enjoy it. You know, just enjoy what you're doing. You know, do it because you want to do it rather than because you have to do it. Involve others, and just enjoy the ride. That would be my advice. And you know, like I said, I can stop writing a paper like tomorrow. I don't need to write anything else, and I can walk away from it all. But I do it because I love it and I really enjoy it. And the more you enjoy it, it doesn't seem like a chore. It's just it's great. You know, it's almost a hobby in itself.
Yeah.
I hope it's been useful. Actually, it's I think, just as we said at the end, enjoy it, do it because you want to do it. You know, that's really, really important advice. And if you do fail in whatever, or you have a paper rejected, or you don't get that ACF or whatever it is, apply again or find another way.
Yeah.
And you know, things always have a habit of working out in the end, don't they? Really.
Yeah, definitely. Oh, well, thank you so much for your time. It's
a pleasure to see you both, actually, at long last. You know, and I wish you both the very best with your PhD. Keep in touch, won't you?
Yes, will do. Nice to chat to you.
All the best.
Thanks for watching, everyone. If you liked our video, then like and subscribe to our channel, or drop us a comment, or email us with any questions or comments you may have, and hopefully see you soon.